computer. So, well, there's Chelsea. To prove that it's a misconception, hospitals will still hire you as long as you have the RN behind your name and you're a fit to their unit. All right. Let's talk about hormones this week. The endocrine system. You guys ready? This is going to be a quick one because there's not much on the endocrine system. There's a couple of questions on it on the exam. So I'm kind of cherry pick the good ones, the more relevant ones. The first part of this lecture, I'm going to talk about some receptor sites that you don't really need to remember, but it's still important to know. But so here we go. Here's my script. So with the endocrine system, it works hand in hand with the nervous system. I need my mouse. The systems work together to maintain internal homeostasis. It works well with this. The endocrine system works together with the nervous system for our heart rate, respirations, blinking of the eyes, everything that has to do with our internal organs, with our bodies. Some of the cells that are produced by these hormones that are produced by these cells, adrenal cortex, intestines, kidneys. If you look at that list, it pretty much tells you everything is controlled somewhere else throughout the body. Characteristics of all these hormones is that they are produced in very small amounts, secreted directly into the bloodstream, and travel through the blood, and it goes to the specific receptor sites where we need them to go. It's not like our beta blockers that has an effect on the lungs and a vasodilator and something else. These are specific to the effect we are looking for. All right, act to decrease or increase normal metabolic process of cells when they get to the receptor sites. And another thing is they are, as soon as our body uses them, we're done. They're immediately broken down. Two things that you need to know are the hypothalamus and pituitary gland, right at the base of our skull. And we'll skip through that. The hypothalamus, this is the master gland of the neuro and endocrine system. This is like the air traffic controller for all the hormones that's in our body. It constantly monitors the body's homeostasis and controls it. If I need my heart rate up, Vanessa Antonio, click Vanessa Antonio already. If I need my heart rate up, it makes adjustments. My heart rate lower, respirations, my mood to change. It changes. This is what controls it. All right, you're in, Vanessa. I feel like you're always late. Maybe it's just me. All right, next. So there's two ways hormones acts in our body. First is what I just explained 2 seconds ago. We have all these receptor sites you see on the screen, from the testes to the bones to the ovaries to the kidneys. They're very specific to what the body needs to do. And the other one is this: they enter the cell, reacts with the messenger RNA, enters the nucleus, and it works through there. It's kind of like the COVID vaccine. It gets in our system and it gives us and it does whatever it needs to do in our system. Two examples of this are the estrogen and testosterone. It gets in our system when we're small, when we're a child, and it gets in our system. And as we get older, it changes us. So it takes time for this to work. That's why the COVID vaccine was a good example, because you get your first shot, it doesn't really work right away. You need a second dose to get it going. And even after you get the second dose, you still need time. It still needs to cook inside your body before you're fully vaccinated, or at least 98%. Major anterior pituitary hormones. I'm going to talk about the anterior and posterior. One is the adrenocorticotropic hormone, which is the first one is the stress response. Follicle stimulating hormones. It promotes the formation of sperm. The luteinizing hormones. This is for ovulation in females. Prolactin is for milk production. Thyroid stimulating hormones is it's a hormone that stimulates the thyroid glands, which controls how fast the body's chemicals function go. These are just a handful of them. Here's the two more. Growth hormone and prolactin are two more. So we are controlling every one of these with the medications I'm going to be talking about. The master pituitary gland, which is the hypothalamus, consists of the anterior and the posterior part of the posterior lobe. Let's go first with the anterior. The first group includes the hormones that can act on the anterior pituitary gland, such as TRH, tritotrophin releasing hormones. It stimulates specialized endocrine cells called T's, thyrotropes, to release thyroid stimulating hormones. Thyroid stimulating hormones. The next is gonadotropin releasing hormones. Stimulates the gonadotropes to release follicle stimulating hormones and luteinizing hormones. This is the reproductive part of the hormones from the ovaries and testes. Next are these two. These are the growth hormones, the reproductive, the ovaries, and the corticotropin releasing hormone that stimulates the adrenal cortex to produce and secrete certain steroid hormones. Next, we have two inhibiting hormones, growth hormone inhibiting hormones, and a prolactin inhibiting hormone, which is the neurotransmitter dopamine that acts to inhibit the secretion of prolactin. It's for the milk thing. Next, kidneys. We are more interested in the kidneys for inpatients' point of view. The kidneys, they produce the antidiuretic hormone, which acts primarily on the kidneys to regulate water balance in the body. So when sometimes your clinical instructor would ask you, what is the sodium doing? Why are we monitoring the sodium? Maybe it's related to the antidiuretic hormone, because it's the patient is dumping out fluids, retaining fluids, dumping out sodium, retaining sodium. That can tell me if the hydration status of my patient. And two more. One more is the oxytocin, which regulates the uterine contractions and milk ejection in females. I guess it can't be in the males. So as you can see, the hormones produced by the hypothalamus, which is the master of the ceremony, they play a crucial role in regulating the metabolism. There is so much parts and pieces into this, from growth, reproduction, to milk. And the medications we're going to be talking about controls all these. Talked about these already. The antidiuretic hormone, I talked about that. We'll skip this part. I have to talk about this part right here, the hypothalamic-pituitary axis. It is part of the neuroendocrine system responsible for the regulation of metabolism, and this is our stress response. How it works is, and there's so much stuff here, but how it works is when the body senses stress, it stimulates the hypothalamus and releases some hormones to the pituitary gland. And depending on which part is causing the stress, it will either give it more or less to put you in a balanced state. I'm not going to get to all the details. It's there in the notes if you want to read it. That's kind of a lot. Other hormones released in response to stimuli or stress. Insulin. If the body senses my glucose level is 500, I'm showing some signs and symptoms of hyperglycemia, it's going to give me some insulin. The body is automatically going to release insulin if everything is working right. Some glucagon, some somatostatin, if I'm, well, the body knows if I'm not growing or if I'm growing too much. Parathormone, parathormone hormones, some regulate serum calcium concentration. Now we're talking about bones, kidneys, intestines. Erythropoietin and renin, kidneys. These two are major players in the kidneys. GI hormones, calcitonin, prostaglandins. This one controls inflammation, blood flow, and blood clots, and also induction of labor. Aldosterone. This is another part of our daily labs that we're monitoring for our patients. It's essential for the sodium conservation in the kidneys and within the bodies. This one, aldosterone, there might even be some medications named aldosterone. It is one that controls it regulates the blood pressure, sodium, and potassium levels. Yeah, I'll skip that. Hypothalamic and pituitary glands. So again, the main function of the endocrine system is to maintain homeostasis. If it's too much of something, it will give me something to take it back down, and vice versa. Leads to various disorders, because if I don't have homeostasis in my body, I'm going to get sick. I'm going to get ill. My blood pressure is going to go up. Heart rate is going to go up. I can't breathe. All these things are going to be off. It's like sometimes you feel, especially in the, I don't want to say elderly women, but I think middle-aged women, sometimes they feel off. They don't know what it is, but so they go see an endocrinologist and they start regulating their hormones and they start feeling better. I'm going to talk about some growth hormones called somatropin. Somatropins. I missed another TO on my slide up there. They're called somatropins. It's a very complex process that requires a coordinated action of several hormones. Deficiency in growth hormone can lead to developmental disorders such as growth retardation and dwarfism. So for the growth hormone, although largely indirectly has an effect on growth, it is one of the most important hormones involved in the growth process. The pituitary gland releases a growth hormone to the hypothalamus, down to the liver, who releases hormones to stimulate bone and muscle growth. So what do we do with these patients? We give them this. That's why there's a typo on my previous screen, because thought I was typing the medicine. To treat this dwarfism, this is one of the medicines they take. I forgot the name of that guy I was going to talk about. Somatropin. How do they work? It mimics somatropin to get them for growth. There's only one indication for this medication, and that is dwarfism. A little bit of dosage there. Sub-Q, 15 milligrams or 1.5 mLs of this. I talked about this in the other class. This is 1.5 ml, which is kind of a lot to be given sub-Q. Remember when you were giving a sub-Q insulin or heparin to your patient, the heparin comes in 1 ml syringe, and the insulin is like 0.002 mLs. So it's very minute compared to this 1.5 ml. That's kind of a lot, especially for a little person, for somebody who has dwarfism. Contraindications for these medications include, just like any other medications, known allergy. That's a given. Presence of closed epiphyses, underlying cranial lesions. What did I say? So what is this presence of closed epiphyses, which is contraindications for somatropin? I'll get to that in a few seconds. Adverse reactions, inflammation, especially from the insertion site. I'm injecting 1.5 cc's of fluid medicines under my skin. Just imagine if that's sub-Q. That's about 1.5, 1/3 of a teaspoon, I think. So swelling, joint pain. This is mainly because the person is trying to grow. Hypothyroidism, and insulin resistance. So what is this closed epiphyses thing? Where are you? There you are. The closed epiphyses means that the patient has reached adulthood and the bones are done growing. That means I can't really give this medicine to this patient because they're done growing. I can give it to them, but nothing's going to happen. And the only thing that's going to happen is give them side effect. So it's a waste. It's a waste of time. It's a waste of resources. And we're putting our patient at risk for the side effects. How are we going to know if the patient is done growing, if their epiphysis is closed? X-ray. There you're going to know. They can look at this line to see if the person is done growing. Okay. So this is what it looks like having a closed epiphyseal plates. I'm not showing you Andre the Giant here on the left side, but his friend looks like he's probably a normal guy. He's done growing. His epiphyseal plates are closed. No, we can give him as much growth hormone as we want. He's not going to get any taller. However, looking at the right side, what's this guy's name? Something Wadlow, the tallest guy in the world. I think he was 8'11" or something like that. His epiphyseal plates never closed. So up until to the age of, I forgot how old he was, I think up to the 40, maybe 40 plus, he kept growing and growing and growing. Here's my drug card for the somatropin. The key for this is I gotta have closed epiphyseal plates. That's what you need to know about this drug. Anything that, and that is because that is not negotiable for this medication. What is this? Somatropin is a hormone of recombinant DNA origin that is equivalent to the growth. I don't think this is true. All right. So we talked about the growth hormones. How about antagonists? So this one is called somatostatin. It's the opposite of what we talked about earlier. So people like Andre the Giant or I think Robert Wadlow, this is the medications indicated for them. So they will stop growing. Because for these guys, it hurts, it's painful, their joints are hurt. I think Andre the Giant had some medical issues himself, but that I'm not familiar with. I know it showed on YouTube or somewhere that he drank a lot of beers. So these antagonists, it inhibits the factor release from the hypothalamus, causing them for the growth hormone to stop producing the hormones. Indicated for treatment of acromegaly and, oh, that's a typo, gigantism. Cautions may cause blockage of other endocrine activity. And what medicine do we give these patients? It's this one. Oh, this is the middle one. You have bromocriptine, octreotide, and somatulene. The middle one, octreotide. Why can't I say that? We use that in the hospital all the time. I don't know why I can't say it. Octreotide or sandostatin. We use this in a hospital. You're going to see this in a hospital for your patient that's GI bleeding. We don't use it in the hospital because we have giants in our hospital. This is also used for GI bleed. To control GI bleed, that's a down payment. We'll talk about this again for GI bleed treatment in a couple of weeks, I believe. All right, so now let's talk about diabetes. Drugs used for diabetes insipidus. There's a difference between, I'm sure you probably remember this from your anatomy, A&P, other medical classes you had, the difference between diabetes insipidus and diabetes mellitus. The latter is high blood sugar. That's the topic next week, maybe in a couple of weeks. Some insulin, that's different. So now this one is diabetes insipidus. With diabetes insipidus, the body is trying to dump out as much fluid as it can. You're peeing like a racehorse. An average person pees about 1 to 2 quarts of urine a day. Versus these people with diabetes insipidus, they're peeing about 3 to 20 quarts of urine a day. And usually if we have these patients in the hospital, we don't like putting Foleys in patients anymore. But with these guys, we want to do that because we want to measure their output in a strict manner. I want an exact number on how much fluid is coming out of the patient. So if the patient is peeing, let's say 15 quarts for that day, I need to be vigilant on what their labs look like. Maybe I'm probably going to need to replace some of these fluid volume. And they're probably also going to need some close neuro monitoring, because now we're talking about my sodium's going up. Is it up? Is it down? My potassium's coming out. What is happening here? So we need close neuro monitoring. Seizure monitoring. All right. The antidiuretic hormone is produced in the hypothalamus and stored in the pituitary glands. The ADH is released to balance the fluid status in the body. The lack of antidiuretic hormones causes DI, which causes my patient to pee, and not stop peeing. Can you imagine if you have this, you're constantly peeing? Aside from being inconvenient, it's gonna mess up your whole system. Now you're gonna be dehydrated. Electrolytes are gonna be off. So this patient is ill and they need to be in a hospital. This is not an outpatient deal. So one thing we give these patients is DDAVP, Desmopressin, treatment for neurogenic diabetes insipidus, and it's also given for hemophilia, a blood clotting disorder. This medicine can be given PO, IV, or sub-Q. Most, actually, some dialysis patients are on this. This medication, DDAVP, also has pressor and antidiuretic effects. Oh, we kind of knew the antidiuretic effect, but the pressor, it only has a minimal amount of pressor effect. So you will, I want to say rarely, but you will never see this used as a vasopressor to get somebody's blood pressure up because it's minimal. How does it work? Same, absorb, nothing there. Liver, excreted in the kidneys. So this medication can be given IV, sub-Q, or PO. And look at the last one, nasally. Ooh, it's on the next slide. There's also a nasal spray for this that the patients can use. Contraindications for this medications is, of course, allergies there, severe renal dysfunction. But there's a question, severe renal dysfunction, but my patient who's a dialysis patient needs this. So what can I do? Well, we give it to them anyway. Most of them, a lot of them are on it anyway, because with the severe renal dysfunction, their kidneys are already shot. So I'm okay to give them some medications that will hurt their kidneys because it's gone. Just like sometimes we have antibiotics such as vancomycin. Sometimes we have vancomycin is highly toxic to the kidneys, but if a patient has bad infection, we will still give it to them, even though we know it's bad for their kidneys. A lot of kidneys have failed because of vancomycin, but in the case of dialysis patients, it doesn't matter anymore because they're already shot. Their kidneys are already done. So we can't hurt it. Known cautions for known vascular disease, epilepsy, asthma, pregnancy, and lactation. This is one of adverse effect of these medications. Water intoxication. Remember, I'm peeing a lot, or maybe I'm retaining the fluid I'm not peeing out. Stimulation of the GI tract, nasal irritation because of the nasal spray part, and hyperinsensitivity, especially from this sub-Q part. Nursing considerations for this. Look at that. Headache, confusion, seizures, sodium levels. What's the theme? If you can't see the theme from here, from my end, you will, maybe in the next few weeks or so, but you will. The theme here is neuro, because as I'm, when my electrolytes are off, especially sodium, it's going to mess with my brain. Then my potassium, my sodium is going to be off. Then might cause confusion. It might cause some seizures. So this patient might need to be on fall risk precautions, seizure precautions. They might need that video camera to watch them. That's depending on which facility you're in. Use of this agent across the lifespan. We use this for children, adults, and older adults. They have a theme too. So for the children, they need to be monitored closely. Periodic X-ray, labs, blood glucose levels should be part of the plan of care. For the adults, we need to monitor your electrolytes and blood glucose. That means you have to come back to the clinic, every 2-3 months and get your blood levels checked. Another part for the adults and older adults is we need to know that they're administering these medications properly. If you're giving if you're doing sub-Q, are you really giving it sub-Q? Or maybe if you're a skinny older person, are you going to the muscles? That changes things up a little bit. If you are taking this medicine intranasally, are you doing it correctly? So we have to educate our patients, because how many times have you seen an asthmatic patient doing their inhaler or COPD? They're doing it wrong and they're not getting the medications, ending at the back of their mouth. And for the older patients, we need to all of the above plus the hydration status. We need to add to the pot. What is this? Oh, I gave you the answer for this one. I don't know if I should add this to the test. It's kind of easy. I gave you the answer already. The nurses came for a 10-year-old boy with growth hormone deficiency. The child asked the nurse how long he'll be able to take this medicine, which is the best response until your epiphyseal plates are closed. But then again, if you're explaining this to I should add it. If you're explaining this to a 10-year-old boy, maybe I'll take that angle. How are you going to explain this to a 10-year-old boy? Epiphyseal plates, what does that mean from a 10-year-old boy? I always, in clinical, we always talk to the patient like they have a second grade education level. So you have to take it down a little bit. True or false? A patient is taking DDAVP and complaining of this is a good one. Complaining of extreme headache, lethargic, and family is reporting altered mental status. Oh, true or false? The nurse expects the provider to provide to order a bolus of normal saline to correct the problem. Pop quiz, hot shots. Should we give my patient a bolus of normal saline because they have a headache, lethargic, altered mental status? True. Normal saline bolus for a headache? Confusion? That doesn't make any sense. Miss Bostic, Miss Vigil, I don't get it. Bolus of normal saline for altered mental status and headache. How about give me some Percocet? How about give me some Tylenol, something? Give me some Dilaudid. Bolus? Are you guys sure? True. Because your patient is in DI, that's why they're getting the DDAVP, and they're dumping tons and tons of fluids, gallons and gallons of fluid. So they're getting severely dehydrated quickly. So true is the answer. I would still prefer the Dilaudid though. Let's talk about adrenocortical agents. or steroids. But we're not going to talk about the bodybuilder type steroids. We're talking about these steroids. I can't breathe steroids, or I'm going to die steroids. Quick review of the anatomy of the adrenal glands. They are flattened bodies on top of each kidney. They're composed of the adrenal medulla, which is the inner core, and part of the sympathetic nervous system. So this adrenal cortex produces the hormones called corticosteroids. For you asthmatic people there, you know what I'm talking about. And this is your medicine we're about to cover. So what is the purpose of these corticosteroids? Stress response, immune response, regulation of inflammation, carbs metabolism, protein metabolism, electrolytes behavior. And the drugs we're going to be talking about are a synthetic replicas of the steroids produced by the adrenal cortex. So stress response, the first one, why do I want to do that? Well, I think it's coming up. I'm getting ahead of myself. So indications of use for the steroids, adrenal agents. They're used for anti-inflammatory effects. They're widely used to suppress the immune system. Let me go back. Anti-inflammatory effects. Why do I want to use anti-inflammatory effects? What does that look like? That looks like right here, this lady, anti-inflammatory effects. I need to give this lady some steroids. She's swollen. She probably, I don't know, let's just say she's allergic to shrimp and she ate shrimp. This is what happens. This is not too bad. True story though. I think it was before COVID. If you guys are familiar with there's a restaurant here in town. It's the Blackout restaurant. You go in, they have everything is dark. You don't know what you're eating. You sign this consent saying you're not allergic to anything. They'll feed you whatever it is, and you don't really know what you're eating. Well, apparently, there was a person who did not know they were allergic to something, and they ate this something. It could have been shrimp or crabs, whatever it might be, and they went to anaphylactic shock, like worse than this lady. This lady ended up in our ICU, intubated for a couple of weeks. And I think we ended up sending her back home to, I don't know, New York or Mississippi, wherever she's from. But this is the steroids we're talking about. And that's why we use it for anti-inflammatory effects. Next is widely used to suppress the immune system. Why do I want to suppress the immune system? Why do I want to suppress the immune system? And short-term use to relieve inflammation during acute stages of illness. In my notes here, I wrote COVID storyline, because in the early stages of the COVID, we were giving patients our standard of care, which was the same treatment for respiratory distress. We would put somebody on a ventilator, give them some antibiotics, typically antibiotics, and usually for COPD patients, if you have pneumonia, you're on this for a couple of weeks, for a couple of days, we extubate you and we send you home. But this COVID kind of changes things a little bit, actually by a lot. Now it was very difficult for us to breathe for this patient. So I don't remember when the study was released, when it was recommended by the CDC, NIH, but we started giving our patients high doses of steroids. And I don't know if it really worked or it was one part that helped our COVID patients, but our outcomes started getting better. So, so now it is part of the standard of care for the COVID patients. I think there was, okay, I think I'll get to that in a little bit. So this, The steroids, especially inhaled steroids, it is typically prescribed for patients with inflamed lungs. That sounds kind of brutal, inflamed lungs. Oh, you can't see, but I meant to show COPD. These are people whose lungs are chronically inflamed and they can't breathe. So we give them inhaled steroids to decrease the inflammation, and they can breathe better. It's also given for a patient with inflamed joints, such as rheumatoid arthritis, inflamed skin, such as psoriasis, lupus, inflamed body, and the allergic reaction. On the other hand, we like our steroids. It works. It gets our patient. We get good outcome, especially for this lady that had an anaphylactic shock. These COPDers, they're on these medications for a long time. Just imagine COPD. What's my average time I'm a COPD? 20, 30 years that I can't breathe. It's probably one of the a brutal way to suffer. So I'm not saying bad about smokers, but it's kind of bad. I'm looking at you right there. Yeah, look up. Yeah, you in a red shirt. I see you. But so these patients are chronically on steroids, and they can go to adrenal crisis, meaning their body is now in overdrive. And this is what happens. Let's forward these. Adrenal crisis. This is the signs that your body is in overdrive. Your adrenals are fried, they're shot. Physiological exhaustion, hypotension, fluid shifting, shock, and even death. I just found out that there's actually a pituitary foundation that deals with these people with adrenal crisis. So what do we do for these patients? Massive infusion of replacement steroids. A standard, in case you guys didn't know, a standard dose for steroids is, let's say, in the hospital settings at least, it's 40 milligram IV Q6 hours, maybe Q8 hours. These guys are getting it 120 milligrams, Q4 hours, Q6 hours. So they're getting the big daddy doses of steroids. And half of them will be in the ICU for constant monitoring and will be on life support. Because if you look at the number 4th here, shock and even death. So now we're dealing with adrenal crisis. We're dealing with that, plus the shock and the death part, which is part 2 of this issue. So these patients are sick, gravely ill. So steroids, how do you know a medication is a steroid? Zone, prednisone, dexamethasone, hydrocortisone, fluorocortisone. It's a gimme, just like your beta blockers, metoprolol, carvedilol, something law. Zones is for the steroids. There's 3 different types of corticosteroids. Number 1, androgens. This one is mainly for the male and female sex hormones. Next is glucocorticoids. Stimulates an increase in glucose levels for energy. Next is mineral corticoids. They affect electrolyte levels and homeostasis. Oh, I think I had my slides off. Causes of, I think that slide was off place, but causes of adrenal insufficiency. A patient does not produce enough adrenocorticotropic hormones. The adrenal glands are not able to respond to these hormones. The adrenal gland is damaged because of Addison's autoimmune response. Maybe they had cancer there and it was surgically removed, and prolonged use of corticosteroid hormone, corticosteroids. What are the actions of adrenocortical hormones? Increase blood volume, aldosterone effect, and cause the release of glucose for energy. And when I'm talking about increased blood volume, I'm not talking about my volume is going to go from, I don't know, let's say I have 15 liters of blood in my body up to 20 with this medications. It's very minute, very small, and it helps a little bit, especially for the renal patients. Another one is the slow rate of protein productions or carb for slow rate of protein productions to reserve energy. Next is block activities of inflammatory and immune systems. Types of glucocorticoids. Prednisone, there's those names again. Methylprednisolone, prednisolone, triamcinolone. I don't know, I've never heard of the third one. It's the first three that are commonly prescribed. Oh, here. This is the recommendations from the NIH for the treatment of COVID. It looks like they added, this one is updated November 1st, 2020, but we were doing it way before then. I think this was just an update, but it was, I don't know when it was originally released. Other types of glucocorticosteroids are beclomethasone, budesonide, can't pronounce that, and the other ones. These two, the top two, these are your breathing. These are for your COPD patients. So if you have a grandpa, grandma, somebody elder who's a COPD, they are more than likely on these medications. And these are the medications, inhaled steroids, that when they inhale, remember your patient teaching for these is inhale, hold my breath. When I'm done, I have to rinse my mouth because it can cause fungi from all the particles of the steroids. That's the key teaching for that medication. Drug-to-drug interactions with the steroids include, it increases effect with erythromycin, with certain antibiotics or antifungals, and toluedomycin. I've never heard of that one. I don't know if it's a typo, but I've never heard of that one. We don't use it as much, or I've never used it at all. So with the steroids, it also decreases when given with salicylates, barbiturates, phenytoin, and rifampin. And this is why your pharmacist is your friend in the hospital. When a physician prescribes steroids for my patient, they automatically, instantly check the drug interaction of these medications. What's the rifampin? Oh, for TB. If I have TB, I'm on rifampin, and the doctor says, "Oh, you need prescribe me steroids," then the pharmacist will check the interaction, and in this case, it decreases the effect of either the steroids. Then the pharmacist will have a conversation with the physician saying, "Dr. Bobby, it's not going to work out because your patient on steroids is on rifampin. So we either need to change the steroids to something else or the rifampin to something else. More than likely, it's the rifampin that's going to be changed to another TB medication." Adverse effect of glucocorticoids. If you don't know this, if this is not common knowledge to you, make it a common knowledge as of right now, 2 o'clock, June 5th, June 15th. Glucocorticoids increases blood sugar. You know that already. If you don't, now you do. Keep that in mind, know it, live it, remember it, because you're going to need that forever and ever, because it's never going to change. Okay. Next is glucocorticoids, also impairs wound healing. It doesn't make it heal faster. It kind of slows it down, increases appetite, causes osteoporosis. That's why some of these COPDers, you will see them, they look brittle. They're walking around. A typical COPD would, that I can picture, it weighs about 90 pounds, skin and bones, with their ribs showing, walking with a cane, because they've been on steroids for a long time, and also their COPD. Mood changes, insomnia, and there's water and sodium retention. There's another reason why, if some of you guys may be asthmatic or have some breathing issues and take some of these inhaled steroids, and stop taking it, because it makes you poofy, it makes you gain weight, it makes you eat more. So, which is what not to do, by the way. We'll get to that. Other adverse effect of glucocorticoids may cause adrenal glands to shut down, must taper dose. No live vaccines. Let me repeat that again. No live vaccines. If I haven't said it yet, no live vaccines. I cannot take vaccines. I cannot take a shot if I'm on steroids. I'm trying to remember now if it was on the COVID vaccine checklist. I don't think it is. Do you guys know why it's not? I'll give it to you. Because the COVID vaccine is not a live vaccine. That's why it's not. But any other vaccine, flu, tetanus, I can't think of any other live vaccines, but no live vaccines. If so, they will tell you to wait until you're done with your steroid dosing and come back for your vaccines. No with the pregnancy, Cushing syndromes, peptic ulcers. MMR, yes, here we go. Thank you. Speaking of tapering the dose, what you see on the screen there, this is a typical PO steroid dosing. This is the first, second, third, fourth, five. This is a 6-day dosing. First day, you take it, what is that? One pill every, I don't know, it looks like 3 hours or 4 hours or so. Then it tapers down, it tapers down, it tapers down. And so this is your a standard Medrol pack that a physician will prescribe you. Come to the hospital side, if we're giving you IV, let's say we're giving you, I don't know, 60 milligrams Q6, we're going to take it down to 40 milligrams Q6, down to 20 milligrams Q6. We will taper it down ourselves. There are 7 S's of steroid precautions. Number 1, you will have swollen legs. Your legs will be swollen from the water retention, sodium retention. Next, sepsis, because your healing powers will be decreased, so you are highly susceptible for sepsis. So make sure you check my temperature frequently if my infection is getting worse. You already know this. Blood sugar. My blood sugar is going to go up. Up, up, up. And here's my, oh, this is not a typical COPDer, but this is what they look like. They're frail, they're brittle. And if these patients fall, break their hip, it can be devastating for them and family members. Next is cataracts. They are high risk for cataracts. So they need a optometrist consult. Slowly taper. We've talked about this already. This is not negotiable. You will, depending on your diagnosis, you will rarely or almost never get a standard dose of steroids from your physician. They will not say, here's, take 40 milligrams of steroids for 6 days, 6 times a week, 4 times a day. You will never get that because it has to be tapered. Next is stress for surgery. Pop quiz, hot shots. I'm diabetic. I am on steroids. Oh, before I get there, if I'm diabetic and I need to get on steroids, I need to contact my physician. I need to contact my physician, if they don't already know it, to adjust my insulin requirements while I'm on the steroids. Because you already know the steroids is going to cause my blood sugar to be up. So let's just say I'm getting 10 units of insulin every day. Let's say 20 units, 30 units every day, long acting. Now that I'm on steroids, this 30 units long acting insulin actually, it's not going to be enough. I need way more than that. So they might need to bring me up to 40 to maybe to the 50 units of long acting insulin every day. But that doesn't mean I'm going to stay there. As soon as I'm done with my steroids dosing, regimen, we will take my insulin back down to where it needs to be. Stress, surgery. So if this is me again, I'm a diabetic, I'm on steroids, I'm going to surgery for, I don't know, I broke my hip, I need brain surgery, whatever, my pinky toe needs to be repaired. My insulin requirements just doubled. First, I have my baseline insulin. Next, because of the steroids, you need to bump me up. Oh, but now I'm going to surgery. That's going to be stress. So now from my next bump, you need to bump me up some more because of this. Because you probably have seen this in a hospital setting where a patient has been lifelong diabetic, and when they get to the hospital setting, we're having a hard time controlling their blood sugars. And this is why. A combination of the drugs we're giving them, stress from whatever the reason they're in the hospital, or actually those are it, maybe even some steroids. So we need to, you're gonna have a hard time fixing their blood sugar levels. And they're gonna ask you, my blood sugar has been under control for the past 20 years, and now I show up here and it's out of whack. And I've been taking diabetic pills for the past 10 years, and now you're giving me insulin because my blood sugar is high. It doesn't make any sense. It does, but that's next week's topic. Glucocorticoids, we talked about this already. How about this pop quiz? The nurse should be concerned when the client states, I have a sore on my left leg, on my leg that won't go away. Which medication should be reviewed by the provider? Select all that apply. What medication is causing this thing on my leg that will not go away? Give me something. A, B, C, D, E. C and E, C and E, C and E, C and E. I'm looking for owns. I don't know. I don't remember these medication. Let's do some test taking skills here. Naproxen, which is Aleve. Let me rule you out. Hydromorphone. Oh, there's an own. dexamethasone, there's a zone, hydrocodone, there's a zone, hydrocortisone. So I have 4 that have the own. But one thing that slows down my healing is steroids, which is your zones, which in this case it's C and E, dexamethasone and hydrocortisone. Hydromorphone is Dilaudid. Hey, I'll take that too if you want to give me some Dilaudid. And hydrocodone. I'll take some of that too if you want to give me some hydrocodone. But so pay attention to the spelling, to the words. They're meant to throw you off. So yes, C and E. Next, which priority teaching is required for patients prescribed prednisone for lupus? Oh, this is a good one. This is a big range of this one. McKenna starts off with the B. B. Is it select all that apply? No, just one. B. Are you sure increased dose before surgery or during times of stress? Yes. But A sounds like it's correct also. Because with this prednisone, there's going to be a slight increase in my blood sugar, right? Wrong. There's not going to be the key word there is slight. It's not going to be a slight. Slight means I don't have to do anything about it. So there's going to be a increase, sometimes even marked increase in blood sugar. Next one is C, monitor weight weekly because of fluid retention, fluid and sodium retention. I might retain some fluid, which I will retain some fluids. Should I monitor my weight weekly? No, ma'am. You should monitor your weight daily. Last, take with a full meal at breakfast. That's irrelevant. Next one. Which of the following is an indication that the client needs additional teaching while taking glucocorticoids? I will not discontinue my bilateral pedal. Looks like all of the above. Looks like all of the above. Damn, McKenna is on the wall. Actually, there's a typo. I should have changed that earlier. This is when I was recording. New bilateral pedal edema is normal. I said period. It's supposed to say, just put a period, not spell out period. But you guys get the point. So let's look at the first one. I will not discontinue this medication abruptly. Good call. New bilateral pedal edema is normal. No, this is not normal. So this is an adverse effect of the glucocorticoids. The most important value to monitor is my weight. Yes, you need to do that daily. I will report signs and symptoms of infection. Yes, because that means whatever infection you have is getting worse or it's not getting better. Oh, that's all I got. Told you this is a short one, a sweet one. That's it. There's only going to be a few questions on this on the test. So that's all I got. Next week is thyroid. I think there was a little bit of thyroid here earlier that I took it out and put it on the next one. Any questions? Good. Any other questions? If you have not sent me your midterm eval, please do so. I've received some of them. and I will send it back to you for uploading. Anything else? If not, no? 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 Who are you? Oh, okay. All right, guys, that's all I got. And I will see some of you guys on Thursday and Friday. Now Sasha shows up. It's over, Sasha. Why are you showing up? We start at 2, actually 1.
I was here the whole time.
Stop. I saw you in the red shirt. I was talking about you there for a minute. All right, see you guys. See you later. Where's my button?